So welcome everyone. This is your session on the future of research in breast reconstruction in Canada. You see me, I'm Tony Zong. I'm located in Toronto. I will allow my three lovely panelists to introduce themselves. So maybe we'll start with Claire and then Perry and Kelly.
Great. Yeah, thanks, Tony. So I'm Claire Temple-Oberly, and I'm a plastic surgeon at the Tom Baker Cancer Center in Calgary. And I'm really excited to answer some questions tonight with you.
My name is Perry Godalovich, and I'm also a breast reconstructive surgeon out of Montreal. And so I can also answer questions in French if you need.
Excellent.
And I can't answer questions in French, but I'm Kelly Metcalf, and I'm a scientist at Women's College Hospital in Toronto. And a lot of my work is focused on surgical decision-making for women who are at high risk of developing breast cancer.
Perfect. So I see that we already have some questions posted on our Q&A. So let's get started. So one question we have from our attendee is, it's sort of a clinical question and I suppose a bit of a research flavor to it too, which is how many times is fat grafting covered by OHIP after a DIAP flap? So maybe I can try to answer that. I believe, so OHIP in Ontario, and I think other than Kelly, I'm the only one that's residing in Ontario. So it's very vague. So OHIP does not actually say how many times it covers fat grafting. So I guess because it is vague, it's up to some subjectivity by the performing surgeon. Most of us do believe that breast reconstruction is a process. It's not a one-time surgery, and there are touch-ups that are needed. Now, fat grafting to contour deformity or areas where there's visible, let's say, rippling over an implant. I think most of us plastic surgeons will say that we will perform that under OHIP and have that be an OHIP cover benefit. Now, there are probably other times when patients do have to pay out of pocket, but that is usually for another purpose. Sometimes at the same time as fat grafting, a patient will want to have some kind of contouring in a different area of the body. So if the purpose of taking the fat is fat removal for contouring purpose, then I think there's a cosmetic component to it. And then I think that the surgeon may charge the patient extra for that part of the procedure. But I think that for the actual reconstructive breast fat grafting to that area should be an OHIP covered procedure for the most part. Claire and Perry, now you guys reside in Alberta, in Quebec. Are there more clear-cut rules than we have in Ontario with respect to that?
Well, Tony, I think this brings up such an important issue in breast reconstruction, and it really is sort of aligned with this whole idea of what areas should we be researching. And I look at revision surgery, whether it's additional fat grafts or whether it's doing another lift or changing out an implant for a larger size or what have you. As you said, it is a process to get to the final result. And even then, it might not be the final result. But at some point, recurrent revisional surgeries, which can happen, and many patients, as you've studied, you've showed how many women in Ontario have repeated unexpected operations related to breast reconstruction, and it's high. At some point, we're probably getting diminishing returns in terms of patient satisfaction and how much we're actually improving their outcome by doing a very small tweak in something that might be almost aesthetic. And I think it's a really ripe area for research is when do we start causing harm by keeping on offering small revisions, and we probably need some assistance in helping us draw the line, because we always want to do more and more for our patients. And at some point, it's probably tipping into the aesthetic, and it's also potentially causing harm if we have complications from upsizing somebody's implant a bit, and then they lose their reconstruction altogether from infection.
Thank you, Claire. Thank you. Perry, your perspective?
So in Quebec, it's to the surgeon's discretion how many times you undergo the fat grafting process. I will say that I'm fairly generous with it because I think fat grafting has improved our results tremendously in terms of what we can offer patients. That being said, I think it depends on the individual patient. So if you do fat grafting and you see very little outcome, what's the point of doing it again? So there are certain age groups in which I think that the fat doesn't really stick as well. But in the younger population, women who have a stable weight and so forth. And I think that fat grafting has helped us tremendously to improve or camouflage the look of especially implant reconstruction. But it certainly is an interesting research point to figure out what's the tipping point of when do we need to stop doing these tweaks.
That's great. Thank you, you guys. Now, because this is a session on research, I actually think that perhaps all four of us panelists here are involved with a research project that actually just very recently wrapped. And I'm happy to say that we just recently submitted our manuscript to the Canadian Medical Journal, which is a very widely read journal in Canada by not just plastic surgeons, but we wanted to reach a broader audience, other healthcare professionals, whether it's GPs, oncologists. So this was a project that all four of us partook in, and it was a large-scale project because it was a pan-Canadian effort. What we wanted to do was really, instead of researching from the perspective of the researcher, which is generally the person that's asking the research question, we actually wanted to give the voice to our patients, to caregivers of our patients, and to just other general support organizations and other stakeholders to let us know what they think the priorities should be in breast reconstruction. So it sounds simple enough. However, the process, if you want to really follow the scientific rigor, was quite involved. It took many webinar meetings with our attendee or with our steering group, and we basically sent out 2 rounds of national surveys to anyone who ever had any interest in breast reconstruction, or patients as well as caregivers who had gone through breast reconstruction or just breast cancer in general. And we asked them to tell us, so we gave the voice to them, for them to tell us what they thought we should be studying in terms of research for breast reconstruction. So we did 2 rounds of these questionnaires. We had to basically comb through so much data and then formulate research questions. Then after we formulated these research questions, we then hired a health services researcher who then went to the actual, scientific literature and examined to see if any of these research questions were already sufficiently answered by, high-level studies. And those that were not, then we took back to the the participants of the survey, and asked them to rank the importance of these questions. So we did an internet survey ranking. And then at the end of this, I think we had a group of maybe 20 or even 30 attendees who gathered in a 1-day workshop about a year ago in downtown Toronto, when we were still allowed to gather back then, in a hotel. And all day we basically sat in a conference room, had open discussions, ranked these questions that people came forth with. And at the end of the day, we generated actually a list of 10 top priorities in research priorities in breast reconstruction. So I thought this would be an interesting forum if other people were interested in just hearing what the participants had to say about what they wanted to see us research. And the number one question by far was the theme of it was on personalized surgical care. And it was that, let's see if I can find it and read it to you word for word. But it was that patients, caregivers, clinicians, and support organizations were most interested in research that can help determine the most suitable breast reconstruction procedure while taking into account both the pros and cons of each surgical procedure and the unique characteristics and demands of each individual patient. So that's a mouthful, but essentially what people ranked as a number one priority was to better help them make decisions around what breast reconstruction procedure would best suit their long-term goals. So
Yeah.
Kelly, I think this is very similar. I mean, this is really along the lines of what you've spent like a decade of your research looking at, how to help patients make more informed decisions that are personally satisfying.
Right. And I think that we have two different patient populations here too. We have those who've never had a diagnosis of breast cancer and are considering breast surgery and reconstruction. And we also have those patients who have had a diagnosis of cancer. And it could be a diagnosis right now where they're making their treatment decisions, which may also include reconstruction, or it could be that they've had a previous diagnosis of cancer. And I think research has come a long way, even in the last 20 years, in terms of thinking about helping people, giving them more evidence to make a very informed decision. And one decision isn't going to be right for everyone. So I think that personalized approach really is important, and people weigh risks and benefits very differently. And I think tonight, even, we've heard about so many different options in terms of breast reconstruction. So it must be difficult for a woman to make that decision. So how can we as researchers and clinicians help women make those decisions?
So I think we have some tools that are available, and some of us have actually have researched those tools that may be helpful in helping patients make more informed decisions. So I certainly know that Kelly has studied decision aids, and there are other tools available that have been used in other areas of surgery or medicine, like surgical risk calculators, which I also find the idea to be very interesting. I don't know how well it can be implemented in this particular area, but I find that interesting. Claire and Perry, you guys are, you both do a lot of research. Do you think that there's a certain method or different methods that can help patients reach this personalized decision?
Well, it's interesting. You brought up a number of great things there that I'd like to touch on. First of all, around decision aids, and I don't know if the whole group knows exactly what those are, but they're a tool that we use to try to help a woman weigh her own preferences and her sort of perception of risk, and so to be more involved in the decision and doing it in a way that's kind of more easy to understand than just sort of statistics that can be kind of hard to digest and understand. And I just took a quick glance at the currently registered trials at clinicaltrials.gov, which is where scientists are supposed to register the trials that they're doing, whether they're randomized controlled trials or whatnot. And I just wanted to peek at the studies that were out there to see how well they corresponded to the top priorities that you and your team came up with. And there was actually quite a number of ongoing trials looking into this number one priority about matching a patient and their expectations and body type and cancer factors to a reconstruction that she will hopefully not regret and be satisfied with. And it really did center around things like decision aids, whether they're paper-based or web-based, different group participatory education of sessions that you're quite familiar with, other decision supports. There's a tool called the Breast Choice tool. All these are sort of designed to optimize decision making. And I think that's one part. And the other part is education, like this evening. So women seeking the best breast reconstruction information they can get from Canadian sources. So, I mean, this is an area that is being looked into, which I think is really exciting, when it was the number one question that women wanted answered with research. And the other thing is you mentioned risk tools. I think it is a researchable question, but it's also something, for example, we use in the clinic with each woman who's seeking information and wanting to make a choice. And so we use the BRA score, brascore.org. And so each health factor of your patient can be put into that, and whether or not they're having radiation or it might be unknown. And it actually calculates medical and surgical risks with percents and types of complications that are particular as best as possible to her situation. And that forms a really nice additional bit of information that you can speak with her about, so that the risk becomes a little bit more real, because sometimes people think risks won't happen to them. But when you see some of these percentages, I think it really helps inform the decision and hopefully helps prevent conflict, decisional conflict, or decision regret down the line.
Great points. Thanks, Claire.
Yeah, that very interesting points. I would just add to that I think one of the key things that I think my role as a surgeon is to help them come to the right decisions for them. And the key for me in that is asking them the right questions. So asking them questions about what is important to them, what parts of their body are important to them, how scared they are of surgery or having surgery attack other parts of the body other than the breast, and to gauge from their reactions what kind of reconstruction would be appropriate for them. Same thing, I mean, I usually do a fairly wide screen in terms of support and how involved they're willing to be in terms of the process of reconstruction, in order to help them gauge also how involved or how invasive a surgery they're willing to accept in order to have a breast. So there's the research side of it, but there's also us as surgeons, I think, synthesizing that research side and bringing it in a palpable way to patients.
So I'm really glad to hear that the #1 ranked research priority is something that we, even though may not be, we're not formally researching at this time, but it's something that we already understand to be a priority for patients, and at least trying in our best way possible to address it clinically. So that's, I mean, I think this is a reason why we all do research in this area, is that there's 100% intersection between our research and our clinical practice, and it's translated, you know, right into clinical practice. It's not something that has to wait years before being put into clinical practice. I think we also had an opportunity to review some questions that were submitted to the Broad Day organizers ahead of today in anticipation of this panel. And I think maybe we'll just deal with some of these questions. I know one question that interested Claire, and that I think also came up in the main session, was on, or maybe it was on a previous panel, was on the practice of nerve preservation during mastectomy and reconstruction, or nerve renervation during reconstruction. So what do we know about it, and what evidence there is? And maybe this time, Perry, I'll start with you.
Sure. So, I mean, I tend to look for the nerves when I'm doing DIEP reconstruction. So the autologous reconstruction from the abdomen, because if there's going to be a big chunk of skin to replace, it's nice for it to be sensitive. And that Aldona is the one who described that in the literature. I personally, clinically, it's kind of been hit or miss. It doesn't work on everybody, but if I can find it and I can find an intercostal, then it's a fairly easy repair to do. In terms of for preservation of mastectomy, my surgeons have not been very open to doing that yet. So I'll let anybody with other experience talk about that.
So Perry, just so I understand, you're looking for a sensory nerve in the abdomen. Mm-hmm. So you're looking for one of those that goes with the perforator, and you're taking that with some length to then,
as much as possible. Mm-hmm.
Okay. Claire, what about, are you doing this in clinical practice, or I know you've researched this in the past as well?
Yeah, it's funny because with when I was training, it was more in the day when we would use the thoracodorsal blood vessels, which is an armpit-based blood vessel, to hook our free flaps into. And that was really nice because the intercostal nerve 4 or 5 was right around there, and it was pretty straightforward to co-opt those two nerves. And then, as the end of my training and my early practice, there was a bit of a shift to start using the blood vessels behind the breastbone. And it was not, I don't think, quite as easy of a co-optation to connect the nerves to the more medial intercostal nerves. So I must say I've fallen off of doing it a bit. However, having said that, the work that I did, I don't know, maybe 15 years ago or so, certainly showed that if you can find something to connect, you can show that the feeling returns. So it's something you can objectively show. And then when you use quality of life patient rated measures, their quality of life is improved by returning sensation, which really makes sense. If you can feel something, it's probably going to improve your quality of life as opposed to feeling something numb. I think it's very worthwhile, and we should do it where we can. And there's other things too about trying to neurotize the mastectomy skin pocket with nerve grafting is another area of research. There's not much written about that. One thing that I find is very troublesome for my patients, especially the implant-based patients, I find they have a lot of post-mastectomy pain syndrome. So where the nerves get cut out laterally, mostly for during the oncologic part of the procedure. And then those nerves don't really have anything to do. They don't have another nerve to join up with, and they just form little blossoms of nerve sprouts that are quite painful. And it can really be a huge issue for women, and the treatments aren't that great. You can try fat grafting, you can try Botoxing, you can take the implant out thinking maybe it's rubbing on them and making it worse, and often things aren't improved. So I think also looking at research where we give those nerves something to do, maybe bury them, maybe sew them to one another, but I think that is a very big quality of life issue for not just reconstructive patients but mastectomy patients. That would be a very worthwhile area to look into. It doesn't totally fit with these priorities, but it kind of does.
So I was very fascinated because there was a paper that was out a number of years ago from Memorial Sloan where I did my fellowship, but they actually, I can't remember exactly how they tested these patients, but they found that patients who were able to have immediate reconstruction at the same time as a mastectomy, and it didn't matter if it was with a flap or with an implant, so those patients who had immediate reconstruction had better preservation of some nerve sensation or return of nerve sensation than those who just had a mastectomy alone. And then if you couple that with the patient reported outcome measures, so which is kind of a quality of life instruments that these patients get, they do report much higher well-being, higher satisfaction with respect to just the sensation on their chest after undergoing immediate reconstruction. And these are reconstruction patients who didn't have any nerves hooked up. So something about immediate reconstruction, intuitively, I understand when you're putting flap, so your own tissue up, it seems like it creates a more kind of a friendly environment for nerves to regenerate. Now, why putting an implant under the muscle also helps to preserve some sensation, I don't quite understand, but this study really supported that finding. So anyway.
I think it's a selection bias, because I think that once the plastic surgeon comes into play, we are constantly, at least I'm always there telling them, keep the flap thicker, keep the flap thicker, keep the flap thicker. And my general surgeons who have a tendency to keep the flaps very thick, those patients have incredible sensation. Like
yeah. Yes.
So I think it has a lot to do with flap thickness. And I think that probably patients who are getting immediate reconstruction, we're kind of selecting them to get thicker flaps.
Yeah, I think that's a good explanation. So we're getting a number of questions here through the Q&A, and one of the questions, or a number of questions, sort of center around donor sites from tissue. So it's around, let's say, the most common, we already covered that one of the most common reconstructions using your own tissue is a DF flap. So it comes from the abdomen. Now, there are questions about, do we think that in the future, harvest of the flap can be done through a more scarless approach? So a less invasive way of harvesting abdominal tissue. Two, is there research to sort of advance the areas to decrease morbidity after abdominal flap harvest? So those kind of questions. And I think another question about a patient who's previously had a tram flap where muscle was from their abdomen was also used in their reconstruction. What advances have we made? So I think that in the last 20 years, we've made quite a lot of advancements in terms of recognizing that that even though we call it your donor site, your abdominal donor site, but we're focused on trying to preserve as much function as we can and minimize the morbidity that's caused by us taking that flap. And one of the things that we're doing now is really being more meticulous when we're dissecting through the muscle and trying to spare as much muscle and trying to spare as many of those motor nerves, which is what supplies the muscle, as possible. And I think that we have done a better job, and which is why we have a lot of us are now training to do DF flaps, as opposed to the old sort of pedicle tram where you just take the whole muscle. I think that there's still ongoing research about how why are there individual differences, and why are some people more likely to have a bulge versus others? Those questions are still, I think we're still looking at it. But in general, I do think that we have done a good job of recognizing the importance of minimizing our surgical donor site. So Claire, do you want to add to this topic at all?
I think you're right with the history of the refinements that have been made on abdominal flap techniques, even to the point where sometimes we don't even enter the fascia or the structural integrity of the abdominal wall, and we're just using the superficial blood supply in patients that are a candidate. These all represent sort of stepwise learning and refinement of techniques. And then we also do things like CT angiograms ahead of time to look at a woman's own personal anatomy to see whether she will be a good candidate for a muscle sparing type of procedure. And if she's not, she may want to consider an implant-based reconstruction, for instance, or something else if abdominal wall integrity is very important to her lifestyle. The problem with the question was around minimal incisions, and the problem with the abdominal wall donor site is it would be hard to imagine that done with minimal incisions, because we often need the skin, and we certainly need the fat immediately below the skin, and trying to hide any incisions and yet get all that fat out to make a breast would probably take away the blood supply of the lower pannus on the abdomen. So I really don't foresee a minimal skin incision per se. But I think we certainly can work on the minimal muscle violation and injury. We recognize it's a huge issue. Women qualitatively talk about a lot of changes in their abdomen that they don't appreciate, like a feeling of fullness, tightness, numbness, pain, itch, clothes not fitting properly, maybe not having the exercise endurance they used to have, or now having back pain. It's recognized to the point that it's a significant part of the developed questionnaires looking at breast reconstruction satisfaction. There are other donor site areas that are more amenable to limited incisions. For example, the back. If you had a back muscle brought in and you didn't need skin, those can be harvested in an endoscopic technique. But that's all I was really able to think about for that particular participant's question.
Yeah,
I think, yeah.
Oh, sorry, Perry. I see some questions here that I think are applicable to Kelly. There are numerous questions here about, so one question, I had BRCA1, had surgery last year. My two sisters had ovarian cancer. What are the chances that my young 24-year-old daughter may develop this? So that's one question. The other on the subject of genetics is, how hard is it to get a prophylactic mastectomy and reconstruction without genetic counseling? Or do you need to have a confirmed genetic cause before you can undergo this. So do you want to
Sure. So let me start with the first question. If I understand the participant's clinical situation and family history, she herself has a BRCA1 mutation. She has 2 sisters with ovarian cancer. I'm not sure if they've had testing or not, but the fact that the mom has a BRCA1 mutation, the chance of her daughter having that is 50%. With every pregnancy, it's like a flip of a coin whether or not that genetic mutation is passed on to an offspring. So at the age of 24 for her daughter, I think it's worth a discussion with a genetic counselor. She may not be ready for testing yet, but she may be. And this is about the age where we would be thinking about doing genetic testing, because we know, especially in a BRCA1 carrier, it's around the age of 30 that we start to see the breast cancer incidence going up. So we would want to either be screening the daughter well with breast MRI starting at the age of 30, or we would be considering some kind of preventive surgery if that's what the daughter wanted. But
so Kelly, her other concern, I think, is also about ovarian cancer. So
for her daughter,
so if I were the mother, that's what I would also be thinking. What are the risks of her developing breast cancer at what age, and ovarian cancer at what age?
Right. So we know with BRCA1, there's the increased risk of both breast cancer and of ovarian cancer. The unfortunate thing about ovarian cancer is we don't have very good screening to look for ovarian cancer, but we're not thinking about ovarian cancer at the age of 24. So usually in a BRCA1 carrier, the recommendations are that she would consider having her ovaries removed at 35 or above, or when she's done childbearing. So for BRCA1 carriers, the option is a prophylactic mastectomy to reduce your risk, but there really is the recommendation to remove your ovaries by 35 or 40. Because we don't want women getting ovarian cancer. We know that the survival rate associated with ovarian cancer is not very high. We don't have good screening. So the best option for these women is to have their ovaries removed. So yes, your daughter, if she did have a BRCA1 mutation, would have an increased risk of ovarian cancer.
Okay. The other question is, I think the question is, how hard is it to get a prophylactic mastectomy with reconstruction without genetic counseling first, or a confirmed genetic diagnosis?
I think it's going to be different probably by province, but I wouldn't encourage anyone to go ahead with a prophylactic mastectomy without first having a discussion with a genetic counselor. I think having that in-depth discussion about your family history, you may think you have a very significant family history, but when you look at it, you have one diagnosis of breast cancer on your father's side and one on your mother's side, but they're both in their 70s and 80s, and it really doesn't mean that you have a very elevated risk of developing breast cancer. So I think it's really worth a discussion with a counselor or some kind of healthcare provider to provide that perspective about what your risk of developing breast cancer really is.
Thanks, Kelly. I think that's very good. Thank you. So another question is actually quite aligned with what our research, the 10 priorities. So one of the priorities that we ranked as quite high was on safety of implants and the safety of newer techniques such as fat grafting. So we have a question right here from an attendee about the worry of developing fat necrosis after fat grafting because it's a lump. It raises a concern about whether or not that needs to be followed, and sending them down the road of ultrasound and mammograms and biopsies again. So safety of fat grafting. So it's back to fat grafting again, but not so much about the cost or about how many times we do it, but about, how should we be studying and how should we be studying safety of fat grafting so we can better alleviate these concerns of fat necrosis and other complications that may arise from fat grafting. Claire,
I
do you
think
want
we've done a fairly good job of studying it both on the radiological side and in a lab to show that it doesn't actually stimulate cancer cells. From my perspective, putting a DIEP up, doing breast reductions, other surgeries where I have a higher incidence of fat necrosis compared to fat grafting, which I actually have a very low incidence of fat necrosis. I think it's fairly straightforward for a radiologist who is versed in looking at fat necrosis. So it's actually not that difficult to tell the difference, to see the fat necrosis versus something suspicious, and certainly not more difficult than looking at a breast reduction breast or looking at a DIEP breast. I do follow my own patients though, and they know that instead of going down the route of seeing somebody who doesn't know what's been done to them, they always come back and see me, and then I'm the one that instigates whatever studies need to be done so that it's well marked on the requisition. Because if the radiologist doesn't know that there's been fat grafting there, that could lead to some confusion. But when they know that the fat grafting's been done, it's fairly straightforward, at least in my experience.
I do think, I know it came in as number 10 on the research priority, Tony, but I think it is still really a great area to look into further. There are certainly in vitro or basic science studies that show that there's certain molecules that stem cells can kind of stimulate that do theoretically have a chance of increasing breast tumor growth. And so it a little bit depends if the woman's seeking fat grafting for correction of a lumpectomy deformity where she still has her breast there versus the touch-ups that we often do for thin mastectomy flaps over implants or divots after autologous reconstruction. That is a little bit of a different situation. I think where the breast has 95% of it has been removed and there's very little tissue to stimulate, I doubt we're ever going to find any worry about fat grafting other than these oil cysts and little lumps can occur and they can lead a woman down this stressful path of biopsy and workup. Even if you tell your patients to come back and see you if they have a lump or bump, they can end up back in the system through their family doctor or what have you. So I do still see that. Versus the woman who has a lumpectomy and wants to have a divot fixed. I always feel a little bit apprehensive fat grafting those patients. I do send them back to their oncologist to get the okay, because I think there probably is a theoretic risk of fat grafting in an old breast tumor, breast cancer bed. I believe the French government also doesn't even allow that to happen because of some of the research that's been done. And so it does make me a little bit apprehensive. I haven't personally seen a recurrence in a fat grafted lumpectomy patient, but I'm glad it did make the list, even if it's number 10, because I think we maybe can do a little bit more research there.
Mm-hmm. So I agree. It came as number 10, but there were other questions that we uncovered from this research priority that really patients had a lot of concerns about different oncologic safety pertaining to different procedures. So oncologic safety, not just of breast reconstruction techniques, but about detection afterwards, detection of breast cancer recurrence afterwards, and the impact that breast reconstruction can have on the future surveillance of breast cancer. So that did come in as one of the top research priorities. So I think I do agree with Claire that I separate fat grafting into a post-mastectomy breast reconstruction into kind of one bin. And the other bin is fat grafting to a lumpectomy defect. I think there was a time when I didn't do any fat grafting to the lumpectomy defect because I just thought that the evidence was still very controversial. And I did not want to be participating in a practice that could, down the road, we find out had really adverse effects on the patient. Now, I think that it has been probably a decade since those oncologic safety concerns have been raised. And so far, we definitely, have not heard a great deal more about this being an unsafe practice. So I have started doing more fat grafting for lumpectomy defects, but the concern is always there. It's different when you've had the whole breast removed and we're just contouring with fat. It's a different situation when you still have a breast that's intact that formerly did have a breast tumor. So let's cover a bit more because our time, well, I'm just getting conscientious of our time. One question that came in was about can DF flap cause any neurological pain? This patient is an anxious person. She has regular aches and pains from fibromyalgia. And she says she has a 50% heart blockage. So she poses this question to us, if we think that, is there any risk that DF flap can cause further, I guess, neurological detriments to her body? So I can take this one first. So if you were my patient coming into my clinic with these concerns, I'd probably want to ask more questions about your fibromyalgia. I do a lot of DF flaps from the abdomen. However, one group that I'm very reluctant to do DF flaps on, that I actually feel is a relative contraindication, are people with chronic back pain. So if you have chronic back pain to the degree that you're really limited in your function and you're on daily pain medication, I think that doing a DF flap, going back to the donor side morbidity, some people do have abdominal weakness from it. And I think abdominal weakness from your rectus muscle is a significant contributor to your core strength. So once you've kind of impaired that part of the core, then I think you put much more of your load on your back. So I think for people with chronic low back pain, I'd really, really have to speak to them about the pros and cons of a DF flap. Now, do I think a DF flap will aggravate just generalized fibromyalgia? I would say to them that the recovery from it is challenging. And I tell most of my patients recovery can be anywhere between 8 to 12 weeks, where I do not want them to participate in strenuous, heavy duty exercise. It's very hard to predict pain after surgery. We do a lot of research to try to prevent it, but who gets pain and who develops chronic pain is still relatively unpredictable, I think. So I don't have a straight answer for this patient, but I would say that it would require a lot more counseling and understanding of what she wants to achieve and her understanding of possible risks and whether she'd be accepting of those risks. Claire or Perry, if this patient walked into your office, would you approach it any differently?
I would generally, with the fibromyalgia patients, I tell them the less surgery, the less areas of your body that we operate on, the less likely we are to aggravate your fibromyalgia. So I would normally counsel them to go with the less invasive approach.
Claire?
Yeah, I think we probably all would counsel in a very similar way. The person indicates that they have, I'm assuming, some coronary artery disease. And, if you're going to have a long anesthetic, and if you're going to be, it's a bit like a marathon, you want your body to be in great shape, and you certainly don't want to have an elective procedure to rebuild a breast that would compromise your cardiac health. Also, we also use the blood vessels that run down the breastbone, and those are the same blood vessels that are used to bypass your heart if you had 100% blockage and you needed to have a coronary artery bypass. So you might want to just talk to your doctor about that too, because you might not want to have sort of use those blood vessels up if you're going to need them for another purpose later.
Yeah, that's a good additional consideration, Claire. Kelly, we have another question. Well, we really have a lot of questions about genetics for you. We have a patient who says that her sister was diagnosed as BRCA2 positive 2 years ago at age 44. Mm-hmm. She herself was diagnosed positive in 2019 at age 52. And now her two daughters, both 26 and 28, have been diagnosed as positive. Should her son proceed to testing?
That's a good question. And I think our thoughts on that have changed a lot over the years. So when we first started this back in the mid 1990s, we weren't really thinking about the men, but now we are, and we know a lot more about the implications for men, especially for BRCA2. We know that for men with BRCA2, they are at an increased risk of male breast cancer. and also prostate cancer. And that prostate cancer tends to be a more aggressive prostate cancer. So yes, I think it's worth a discussion. Again, it's going to be an individual decision on whether or not he wants to be tested. He also may have children that this would have implications for as well. So there's a variety of factors that he needs to consider in terms of whether or not he wants to be tested.
Thank you.
Actually, I don't know where she lives or her son lives, but there is a great clinic at Sunnybrook Hospital in Toronto that follows men with BRCA mutation and does all of the cancer screening and follows those men in the long term.
That's great. So Kelly, I just got a message from Mitch that we have to wrap things up, but just because there are a lot of questions pertaining to genetics, where do patients go to? Is there a website that they can go to where they can resource where the genetic counselors are located, which hospitals have this? How do they do that?
Yeah, there is a Canadian Association of Genetic Counselors. So you could visit their website and that will give you some information about where in relation to where you live, where you can access a genetic counselor.
Great. With 1 more minute to spare, Claire or Perry, is there anything else you guys want to relay to the attendees tonight?
I mean, there's just so much to talk about in the area of research. I think what's really exciting is now we've kind of heard the Canadian public and know where we should be focusing our efforts so that we're not doing studies that are clinician generated and not really what women and their families and caregivers want us to be looking at. So I'm really pleased and excited about the future in breast reconstruction research that we have this guidebook to go by. So I'm very appreciative to you and your team who have done this priority setting. And when I look at all the questions through the Q&A, so many of them are really aligned to what you found. So I guess I think it's a really great time in breast reconstruction research with this guidebook to go by.
Thank you, Claire.
Yeah, agree that we've come a long way, even since I was in training, and I'm excited to see what the next 10 years will bring.
Well, I think we're all in it together. And I think what the nice thing is, as I said before, the reason we do clinical research is because we can directly put it into our practice. And the intention is to really find ways to optimally do our job so we can best benefit our patients. So I think this is why we find this so rewarding. So on that note, I would like to thank all my panelists. I'd like to thank so many people for attending this session. This is wonderful, and hope we've been able to share with you the research and answer some of your questions. Mitch would like, I think, everybody to check back into the main session. There's some closing remarks.
Thanks, Tony.
Thanks, Tony. Bye. Nice to see you.
Bye, everybody.
Happy Broad Day. Bye.
Happy Broad Day.